In today's episode of Frontiers in Kidney Medicine and Biology, we discuss many aspects around dialysis prescription for a person. My guest is nephrologist Dr. John Daugirdas, clinical professor of medicine at the University of Illinois School of Medicine at Chicago. In the dialysis world, he's a household name and one of the leading figures in the field. He has published about 300 papers and developed methods of dialysis dosing that are used widely today. John, welcome to this series of Frontiers in Kidney Medicine and Biology.
Thanks, Peter. I think it's a wonderful program you have, and I'm very happy to be part of it.
Thank you, John. So when I went to PubMed and would type in Daugirdas J, I saw that your work really dates back to the 1970s. This is quite remarkable. And I'm wondering, John, what have been the major advances in dialysis in the past 30 to 40 years? Is it technology? Is it processes? Is it drugs? A combination of that? Well, how do you see that from your vantage point? I mean, you got really the long view here.
I passed my nephrology boards in 1981, and of course before that I was a nephrology fellow and starting research. At that time, coil dialyzers had just stopped being used, and we were still dialyzing with plate dialyzers, where the membranes were arranged in a series of parallel plates, and hollow fiber dialyzers was just beginning to be manufactured. And also people were looking at new membranes, and were looking at synthetic membranes for the first time, and membranes that would allow high flux passage of larger molecules through the pores, specifically polyacrylonitrile. In terms of the actual dialysis procedure, not that much has changed in those 40 or so years. Membranes have been improved. There are many more different high flux membranes that are good. The dialyzer membranes at the time were made out of cellulose, and cellulose on contact with the blood would activate complement. This would cause some inflammation, such that 30 minutes into dialysis there used to be a large fall of the neutrophil count, sometimes as much as 70 or 80%, which then would go up. Sometimes this was associated with chest pain and back pain. There was a time period when hollow fibers dialyzers were just manufactured. They were sterilizing them with ethylene oxide. This would soak into the potting compound, sort of the goop at the end of the dialyzer that anchors the potting compound, and leach out during dialysis and cause anaphylactoid reactions. This has been taken care of. But really, dialysis has not really changed that much. In fact, in a way, it's gone backwards, because when I started out, there was an emphasis on home hemodialysis. We had a large number of home hemodialysis patients at the VA hospital where I trained. Initially, people were talking about longer dialysis treatment times, 3 times a week. Some people were dialyzing with daily dialysis. John De Palma in California was advocating daily dialysis. And this was back in the 70s and 80s. There have been some advantages in terms of the machines. The main advantage was controlling precisely how much fluid is removed during dialysis. In the early day machines, you had to sort of guess the pressures across the membrane and adjust the pressures, which then would then adjust how much fluid was removed. Now they have volumetric means of removing fluid, so you can precisely dial in no fluid removal, or removal of 1 liter per hour, or half a liter per hour, whatever you like. But the basic dialysis procedure really hasn't changed. Now there's some newer membranes. When you dialyze patients, the normal kidney removes molecules up to molecular weight of 40, 50,000. And the sort of low flux dialyzers remove very few molecules in the higher molecular weight range. One of the things that we measure is beta-2 microglobulin. And with the low flux dialyzer, with the low flux membrane, no beta-2 microglobulin is removed almost. But even with the high flux membranes, you don't remove that many molecules in the 20 to 40,000 Dalton range, the 20 to 40 kilodalton range. And so now they have these membranes called medium chain cutoff membranes that that remove these higher molecules, these larger molecules. But in terms of the procedure, not that much has changed. The other two parts of your question are drugs and process, and I think with drugs there have been major advances. And the first one was erythropoietin. When I started out in dialysis in the 80s, it was very common to have people with hematocrits in the 20s, people requiring transfusions all the time. And erythropoietin really changed the ball game in terms of treating anemia of dialysis. Many people were taking phosphorus binders containing aluminum. Aluminum poisoning was really prevalent in the 70s and 80s because of ingestion of aluminum containing phosphorus binders. This was reflected by bone disease. It actually had problems with dialysis dementia. So now aluminum-containing binders are very rarely used. Then the next step was calcium-containing binders, and there was an issue with, even though calcium-containing binders can be safely used, and some are widely used, calcium carbonate contains 40% calcium, and to get the required amount of phosphorus binding, you would be giving patients an equivalent dose of 2 grams of calcium a day. This was too high and was associated with vascular calcification, especially calcification of the coronary arteries. And now we have better binders. We have binders that are more effective, binders that contain no calcium, so that problem has been solved. And the most recent sort of binding drugs are the Patiromer ZS Pharma drugs that bind potassium and that can help us control potassium. So I do believe that in terms of drugs, there have been major advances made. And I think now we better understand which antihypertensive drugs lower cardiovascular risk in dialysis patients, specifically Dr. Agarwal's work with the beta blockers. So I think in terms of drugs, we've made major advances. Probably the biggest advance is process. When we were doing dialysis in the early 80s, there really wasn't this concept of quality improvement, of quality management, and especially of getting patient feedback, patient-reported outcomes. And I think that the emphasis on this has been very, very good. Getting information for patients, and I think it should be much more. Currently now the quality outcomes are measured in patients once a year with a long questionnaire. I think the future is going to be assessing just a few simple questions regarding how patients are doing, and doing it multiple times, perhaps even every day, where they would have maybe 5 or 6 simple questions to answer how they're doing and answer it every day. And there's some very interesting work done saying that if you follow patient reports of how they feel and follow it every day, if you can pick up a change very early, and very often this change will predict an adverse change in their health, and there's a question of perhaps you can intervene. One area has been, for example, vascular access. By just asking patients every day how their vascular access is doing may give you better warning of a failing vascular access as opposed to fancy tests. The other process improvement that's taken place, I think, in the United States is, and it's still ongoing, is limiting the use of catheters for vascular access, and perhaps also of grafts, and increasing the use of arteriovenous fistula. And so there's some questions about whether there's a limitation to this, especially in the elderly patients, but certainly the probably part of the benefit in survival and hospitalizations that have been noted in the past has been in the area of emphasizing, putting in, I don't know if, I presume your audience will know what an AV fistula is, but when you do dialysis, obviously you need to have some access to the blood, and so the safest access is to hook up an artery and a vein, and hook them up surgically under the skin, so nothing sticks out from the skin. There's no portal for infection, and then when you dialyze them, you put one needle into the upstream part of the access before the loop, and another into the downstream part of the access. And I think there's a whole other dimension in terms of perhaps a single needle access. You can do dialysis from a single needle with reversal of flow. And then the final axis of process is people are realizing that one of the major problems that dialysis patients have is not only removal of uremic waste products, but control of salt and water and fluid balance. And so the big question is, can we somehow measure and optimize fluid balance in our dialysis patients? I mean, basically, dialysis patients will take in, say, 7 to 11 liters of fluid a week, a little bit more than a liter a day. So if you dialyze the patients 3 times a week, on Monday to Wednesday, you'll have to remove 2 liters, and over the long weekend, you'll have to remove 3 liters. And this sort of sawtooth pattern of fluid is harmful to patients. And number one, there could be fluid overload all the time, even at the end of dialysis, but sort of the accumulation of fluid that's not removed during this interdialytic interval can cause cardiovascular problems, can accelerate left ventricular hypertrophy, can accelerate vascular damage. And so the one problem is you want to avoid this fluctuation. And how do you avoid it? Well, you can avoid it on the intake end by usually the amount of fluid a dialysis patient takes in relates to how much salt they take in, because the sodium tends to drive thirst, thirst tends to drive fluid intake. However, it also drives food intake, and once you start to do any kind of restriction in dialysis patients, number one, you can tend to restrict their food intake, which is bad, and also you complicate their relationship with their family and caregivers, because if you want to put dialysis patients on a very low sodium diet, sometimes their food is prepared in the family, you have some family cook, other people in the family don't want to be forced into a low sodium diet. Some dialysis patients eat largely in restaurants. Their only access to food may be sort of food that they eat, they get from fast food places and restaurants. And it's very difficult to restrict sodium intake in dialysis patients, but it is necessary. And when it has been done, it limits the amount of fluid gained during the dialysis treatment. Whatever fluid that you gain during the interdialytic interval, which is that period between the time you get off of dialysis and the time you get on dialysis, has to be removed, and has to be removed in 4 hours. So if you gain 3 liters of fluid, say over the long weekend, and then you are dialyzed for 4 hours, you have to remove 800 mils per hour of fluid from that patient during the dialysis procedure. Now the patient's blood volume 5 liters, so plasma volume maybe 3. You basically have to remove the entire plasma volume in a course of a 4-hour interval. And then the only way you can do this is because as you remove fluid from the blood space, you get what's called refilling. Fluid sort of migrates from tissues around the blood vessels back into the vascular compartment, so you don't totally deplete the blood volume during the time that you have your dialysis treatment. However, this still causes hypotension in a number of cases and low perfusion. And now we know that dialysis that's associated with rapid fluid removal is associated with damage to organs and stunning. And the key organs that people have been looking at have been the heart, and they've done fancy imaging of the heart during dialysis procedures, and they show that the actual ventricular wall motion abnormalities are altered, suggesting that the myocardium is not getting enough blood during dialysis. There's also stunning in the brain. There's evidence of ischemic damage to the brain in dialysis patients, and this has been associated with low perfusion. And then when people look at the microcirculation during dialysis, they find out that regardless of the blood pressure, there's also changes in the microcirculation, so that blood doesn't go through these very small capillaries for whatever reason during the dialysis procedure. And the problem is it's not that easy to figure out how much excess fluid a patient has. Sometimes you can look at a patient, typically in a non-uremic patient, you can look and they sort of have, as a medical school students are taught, If you have fluid overload, it tends to back up in the veins. You have jugular venous distension. You can see pulsation in the veins. You get typically edema. You get edema of the legs. You get edema elsewhere. Pretibial edema. You get it presacral edema. And the problem is sometimes in a dialysis patient they can be markedly fluid overloaded, and there can be few signs of fluid overload. Of course, if you listen to the lungs, sometimes you can hear rows. And so physical exam is not that useful. So there are multiple technologies that now are just sort of starting to be looked at that might help us. I know even as a medical student and resident, I always had trouble. It's not that easy to tell sometimes to what degree a patient is fluid overloaded. And so technology can help. There are a number of new technologies. One is bioimpedance, which looks at the resistance to electrical current that going through the body that can give some idea of to what degree of a patient is overloaded. Other technology looks at the lungs. You can do an ultrasound of the lungs, and then you can, in patient, when the lung is, you can say, well, what's more important than fluid overload somewhere in the legs is how much extra fluid you have in the lungs and the central circulation. And a good test of that is to do lung ultrasound, and you can see sort of these vertical lines that appear, and you can count those, and that gives you some idea if the lungs are overloaded. There's some jackets that people now are being tested in heart failure patients that also give you a measurement of lung water. Whereas the basic technology for dialysis has not improved very much. Certainly drugs have improved, processes have improved, and technology with regard to fluid overload, some of this is fairly exciting. And I do think that that's something to look forward to.
Thank you, John, really for sharing your view on these questions. I guess it's really that there was, well, as you say, the fundamental of dialysis, meaning removal of solutes following a concentration gradient, has not changed. The physics hasn't changed, but many of the components involved have changed and have been improved, where in both technology, both processes, and of course also drugs. Now, when I was for the first time exposed to dialysis, I believe it must have been as a medical student. Dialysis was called as the quote-unquote artificial kidney. And first I was impressed that dialysis, or the dialyzer, is the artificial kidney. But then I felt it's a huge overstatement, because, I mean, while in the kidney, or in the glomerulum, you have a filter that, for example, lets larger molecules pass. In the kidney, we have a delicate, highly developed system like the proximal tubule, Henle loop, distal tubule, countercurrent system, etc., where most of the substances that are actually filtered are regained. But this is not the case in dialysis. There is no regain of substances, at least in the way how we know dialysis now. So what's your view on that? This talk of creating membranes that look like the glomerulum. How relevant is this when you do not consider that you don't have this intricate, highly effective system of regaining molecules, be it proteins, be it others?
That's a very good question, Peter. And so the kidney basically is a filter connected in series with the reabsorber. So what happens is you filter 180 liters a day of ultrafiltrate from the plasma that contains all the dissolved solutes. And then you only excrete 1.5 liters of that. So when you start reabsorbing that 178.5 liters during the day, the kidney is very smart, and it can selectively alter what it reabsorbs. It's sort of like a smart machine. So the kidney can reabsorb more acid, it can reabsorb more base, it can change the amount of sodium that it reabsorbs, change the amount of potassium reabsorbs, protons, as I mentioned. So the kidney is a very smart, I know when I was in medical school, people were saying, well, why do you want to be a nephrologist instead of a cardiologist? Well, you know, cardiologist is basically just a stupid muscle. It just pumps and that's all it does. The kidney is really a very, very sophisticated computer and device and machine. And that's not even talking about the other metabolic functions of the kidney. You have manufacturing erythropoietin, you have hydroxylation of 125 vitamin D, you have gluconeogenesis role, you have this role in metabolism of certain amino acids. Some people are trying to replicate the role of the kidney by seeding the fibers of a hollow fiber dialyzer with kidney cells to sort of replicate some of that smart function. On the one hand, it's very simplistic to say, well, and the kidney does because it filters, it will remove molecules. Albumin has a molecular weight of about 60,000. And of course, albumin is held back by the kidney. Part of that is because of its negative charge by the glomerular basement membrane. But the kidney will filter out many compounds that are up into high range, into the 20 to 30, 40 kilodalton range. And so the big question is that if you somehow enlarge membrane pores, if you make them too big, then you start losing albumin, which is considered a bad thing, because of course albumin is probably the single best marker of survival in patients for any reason, is what their albumin level is. So you don't want to lower the albumin levels. You don't want to make the holes in the membrane too large, otherwise you'll start spilling albumin. Now there's one theory that losing some albumin may be good, because one thing that you have, one class of uremic toxins that you have are tightly bound to albumin. They're called protein-bound uremic toxins, and you can't get rid of those by normal means. Normally they're stripped from the albumin in the kidney, in the distal tubules. One idea was that if you lose a little bit of albumin, such as that you do during peritoneal dialysis, maybe that's a way of removing protein-bound uremic toxins. But in general, you don't want to make the hole in your membrane so large that you start spilling albumin. But you want to start getting rid of some of these compounds. Beta-2 microglobulin has a molecular weight of 11 kilodaltons. So you have this range from 11 to 40, where you have a lot of substances that accumulate in uremia and that are associated with inflammation. And the idea is that if you could make a membrane that gets rid of these compounds, will you improve the situation? The problem with some of this is, if you look at drugs, you have sort of a sigmoidal dose-response curve, right? So you have people who know pharmacology that you have very low quantities of a drug does nothing, then at a certain concentration the drug starts to become active, and then as you increase, and if you're on that steep part of that sigmoidal dose-response curve, changing the concentration of that substance will make a big difference in terms of the efficacy of a drug. And then once you get above a certain point, giving any more of that drug doesn't have any effect. So you're on the upper part of that S. And the problem is that if you look at the plasma concentrations of some of these very large molecular weight substances, even for example, if you take beta-2 microglobulin, the normal concentration of this substance is 1 to 2 milligram per deciliter. So in a dialysis patient that's being dialyzed with a membrane that doesn't pass any beta-2 microglobulin at all, and has no residual kidney function, the beta-2 microglobulin level will be around 30. So you're talking more than 10 times the normal value. So the big question is, and if you can, obviously with the high flux membrane, you can reduce this level down to about 25, 24. And then if you jump through a lot of additional hoops, you might get it down to a range of 19 to 20. But the question is, if you're taking the concentration of some substance and you're reducing it from, say, 30 times normal to 20 times normal, are you already on that flat part of the dose-response curve that you're not really making a big difference? And maybe to make a big difference, you might have to reduce it down below 10 or below 5, which is what you have when you have substantial residual kidney function. So I think the jury is still out. They can show usually a decline sometimes of up to 20-30% when you use these membranes with these larger pores. But the question is, are you making a clinical difference? Does the patient's survival, does the patient's quality of life improve?
My concern is also a little bit that we may lose beneficial substances. We may lose binding proteins for hormones, certain coagulation factors that are relevant in the immune system. So, but as you said, jury is still out there. Now, let me change a little bit gears here, John. So, almost like a drug, dialysis has to be dosed in a way, right? And so a question is really, how is the dosing of dialysis accomplished, and what is the dialysis dose, and how would people actually come up with a dialysis dose?
The story of dosing is back before, when I became a nephrologist, people would look at two substances in the blood that accumulate in dialysis patients. One was urea, one was creatinine. So urea is actually by itself is not a very toxic substance. Urea is the way that the body detoxifies ammonia, and urea is manufactured by the liver. You have carbohydrates, you have fats, and you have proteins. So carbohydrates and fats contain no nitrogen, but proteins and proteinaceous substances do. And so you have to do something with this nitrogen, excrete the excess nitrogen. Of course you can recycle it, but somehow the nitrogen from proteins in the body has to be excreted. And then the liver takes that ammonia and makes it into urea. So as you know, when you treating cirrhotic patients with alcoholic cirrhosis, you get ammonium toxicity, and they're not making urea. So urea is a good thing, not a bad thing, in the relative toxicity scale. Although now there is some new late evidence that urea itself might be relatively toxic. In any case, one of the ways that people were looking at dialysis, so normally your urea concentration depends on how you measure it, but the way we measure it in the US is 5 to 20. So in dialysis patients, it's commonly to have pre-dialysis urea concentration of 40 to 60. And back in the old days, you would often see a uremic patient with urea concentration. We measure urea nitrogen, not urea, but urea nitrogen of 100 or higher. So one idea was, first, is that you could just look at dialysis patients and look at the level of blood urea, and if the level of blood urea was high, it would be bad. If it was low from dialysis, it would be better. And then they found out, to their surprise, is that sometimes patients with lower blood urea concentrations had a worse outcome than higher urea concentrations. And at first they were scratching their head, and then they figured it out, is because the more protein you eat, the more urea you generate. And the patients with the low blood urea level had a low blood urea levels because they'd stopped eating. They were feeling terrible, and this is why they had a bad outcome. So people quickly realized that just looking at the blood level of urea was not a good measure of the adequacy of dialysis. So then there was a major randomized trial done called the National Cooperative Dialysis Study, which was designed to look at the levels of urea, a higher level and a lower level of urea. And then the people who looked at that study reanalyzed it in terms of looking at, they also measured the blood urea level before dialysis treatment and after dialysis treatment. And they looked at the percent reduction of urea. And they said, well, what's important is not what the blood urea level is per se, but what's more important and what gives us a better idea of survival is how much the urea is reduced in a dialysis treatment. And what they found is that in those dialysis treatments where the reduction of urea was very low, there was a poor outcome. There was high incidence of treatment failure, and that then there was when the proportion of urea reduction ratio was high, there was a much better outcome. And the outcome, somehow the dividing line was around 60% reduction of urea. So above a 60% reduction of urea, the outcome was okay. If the percent urea reduction was much lower than 60%, and these were patients being dialyzed 3 times a week. And so they found that the outcome was a lot lower. And then this was translated mathematically in terms of fractional excretion of urea, and this whole concept, what's called KT over V. And what they found is that if you take the clearance of urea times time and divide by the volume of distribution of urea, which was V, so the clearance in nephrology is called K. And the reason I always was wondering about this, because K is like a mathematical constant, and you would think that they would call clearance C. But the reason it's called K is because back in the early mid 20th century, much of the important physiology was done in Germany, in German-speaking countries, and the word for clearance was Klärung. I think so, anyway. And so that's why clearance is abbreviated as K. Anyway, so they translated this urea reduction ratio of about 63%, 60% translates into a KT over V of about 1. And so that's where this concept came out, that we can just look at the reduction of urea in a given dialysis treatment, and this will give us our dialysis adequacy. And so when people looked at large databases and looked at survival as a function of urea reduction ratio, or KT over V, they got a very nice sort of a curve where the mortality rate was markedly increased when the urea reduction ratio was less than, say, 60%, 65%, or the KT over V fell below 1. And so the initial, as a result of this study, the initial sort of guidance was we need to keep a KT over V of at least 1.2, a urea reduction ratio of at least 65%, to get minimally adequate dialysis. There were a number of issues and problems that this system of dialysis dose engendered. And one of these problems was that in a small patient, you could get KT over V, you could reduce urea by more than 65% very quickly, in a couple of hours, because the patient was small, and the clearance part of the urea from the dialyzer could be very large. So in small patients, in women, you could get a clearance of 65% urea reduction, or KT over V, in, say, 2 hours. And the question was, is this okay? Because the problem is, dialysis is not only associated with removal of urea. Urea is very quickly dialyzable. Urea has a molecular weight of 60. So remember, the blood only spends about 15 seconds in the dialyzer. Normally the dialyzer has a volume of 100 milliliters, and your blood flow rate is 400. So your blood is rushing through the dialyzer in 15 seconds. And those things like urea that dialyze like crazy, it can actually clean out the urea not only from the plasma but also from the red cells in that 15 seconds in the dialyzer. But urea is not at all typical of how other solutes behave, how larger molecules behave. So the question came up was that if you dialyze smaller patients with a high efficiency dialyzer and can get this urea reduction ratio of 65% or higher in 2 hours, is this good? And the other issue happens to do with fluid removal. We just talked about, you're going to gain 3 liters of fluid over the weekend. And if you remove that over 4 hours, then you have to remove 800 mils and change from per hour. Well, if you're only going to dialyze in 2 hours, then you have to remove 1.5 liters per hour. Can you do this? And so that when you shorten the dialysis time, you have to do a much more rapid removal of fluid, which may cause severe adverse effects. And the other issue is large molecular weight substances, and even phosphorus and things like vitamin B, things not things that are very, very large, like beta-2 microglobulin with 11 kilodalton range, but even substances like vitamin B12 as a marker with a molecular weight of about 1 kilodalton, 1,000. You wind up not removing adequate amounts. So there was a sort of a realization that perhaps this URR KT over V measure was not the best measure of dialysis adequacy. And then the other issue, and this is why the HEMO trial was done, is when they looked at these sort of mortality curves of KT over V or urea reduction and mortality, they found out that even once you went above a KTV of 1.3, 1.2, that if you went up to 1.7, which is a urea reduction ratio of about 75% or so, that you got a continual improvement in mortality risk. So that's why the HEMO study was done, and they compared a urea reduction ratio of 65% with about 75%, or a single pool KTV of 1.3 and 1.7, to see if additional removal of waste products would give you a better benefit. And they found out that there was no additional benefit overall for additional removal of these small molecular weight substances. So that was the first sort of and that's still, but if you look at quality improvement standards, KT over V and urea reduction ratio is still the main quality improvement standard we looked at. And it's a way for a payer or the federal government to look at, saying, okay, you're telling them that I'm providing dialysis, pay me for it, and they'll say, well, you have to show that the dialysis you're doing is effective at least to a certain minimal level, and I think there's nothing wrong with that.
I was still thinking about the fact that the so-called artificial kidney lacks this whole reabsorptive machinery. So in my mind, this begs the question, is there something like over-dialysis? So is there actually a range where dialysis is just so highly efficient in terms of urea removal that indeed you also lose so many other beneficial substances that actually the survival may go down? Is there any data to that effect?
There are some actual clinical data. So there was a movement afoot, and it started out largely in Canada, of doing dialysis overnight for 7 hours, sometimes even up to 8 or 9 hours every night, putting patients on the machine, this is all done at home, of course. So doing dialysis at home, putting the patient on the machine in the late evening, wake up in the early morning. And now some units are doing this, but they're not doing it every night. But anyway, in the Canadian approach, they were giving dialysis 6 nights a week. So if you say that each dialysis treatment is, say, 8 hours, that's 48 hours of dialysis a week. So what you're talking about is 24 hours in a day. If you're dialyzing 8 hours every day, you're spending 1/3 of your time on dialysis hooked up to a machine, which is incredible. It's almost like having kidney cleaning 1/3 of the time that you're alive. And you would think that this is wonderful, that these patients would have very, very good outcomes. And this was one of the arms of the what's called the Frequent Hemodialysis Network trial, the nocturnal trial. And they didn't achieve such a high dialysis in everybody, but in certain patients they did. And we were able to look at outcomes in those patients. So there were 2 adverse events that were identified, actually perhaps 3. One was, of course, is not an adverse event, it's well known, is that if you dialyze patients to that degree, you will remove too much phosphorus to the point that you will get hypophosphatemic, to the point that if you don't do something, these patients will have severe hypophosphatemia and they can have complications. When you start getting into serum phosphorus levels below 1.5, you start getting cardiac, respiratory signs. It's not something. So they fixed that by adding some phosphorus to the dialysate. And it's an open question whether something else was lost in terms of substances. Now, there was no evidence of an adverse effect on erythropoietin, for example. There were no evidences of increased infection rate. There was maybe some signal for actually a few more increases in deaths. There certainly weren't any decreases in deaths in the FHM trial. One thing that was found was that in those patients that started dialysis with this aggressive regimen that had substantial residual kidney function, nocturnal dialysis to that degree, once you gave more than 24 hours of dialysis a week, the kidneys would tend to shut down and you would lose all residual kidney function at a much more rapid rate than in patients who had a control amount of dialysis, which was 3 times a week for 3.5 to 4 hours per treatment. So there is some loss of residual kidney function. Now the question is, why does this happen? Is it because you now are keeping people at a much lower fluid level such that you're kind of lowering the perfusion rate to the... We know that the end-stage kidneys cannot auto-regulate, and so they're much more sensitive to ischemic damage, to low blood pressure. So one question may be is perhaps when you spend this much time on dialysis, there's an adverse effect due to perfusion on the kidneys. The other thing is kidney flow in GFR is driven by osmosis, osmotic gradient, and urea participates in this. And we know, for example, even if you look at residual kidney function and measure it during the post-dialysis days, residual kidney function picks up on day 2 post-dialysis versus day 1, and it's even a little bit higher during the long weekend on day 3 versus day 2. Some of this may be volume related, some of this may be the fact that you have a higher osmotic load. Then there's another issue too, is we tend to think that dialysis is harmless. And, I go back and think about the artificial heart patients, back about, 20 years ago, they did the first total artificial heart implant in patients. And one of the big problems when you have a totally implanted artificial heart is you have activation of blood elements by the surface that the blood has to flow through. And so they spent a lot of time optimizing the flow dynamics of an artificial heart to make sure there are no corners, no this, no that might activate the blood, may cause clotting or may cause some problems. So now if you look at the dialysis circuitry, it's really quite primitive if you think about an extracorporeal circuit. You have the needle, then you have these blood lines, you have pressure sensors in the blood lines, you have a venous air trap, you have the dialyzer membrane. And it's been shown that when you put patients on dialysis, even though they sort of solved the complement activating problem by optimizing membranes, there's still a lot of platelet activation that takes place whenever you put patients on a dialyzer. And there's also another problem related which is called microbubbles. Somehow, there's some systems that now are looking at this and trying to optimize this. But it's very difficult to avoid microbubble injection into the blood. It even gets through this. It even gets through the venous air trap, and it's not picked up by the detector. And the problem is that these microbubbles get into the circulation. They can activate platelets. They can cause aggregation of platelets and neutrophils. And so, if you look at a cardiologist, they'll talk about whether you give 1 or 2 antiplatelet medicines to prevent, cardiac events. So there are these sort of dialysis maxis, now I'm into cryptocurrency, so I learned this term called maxi, where they just sort of believe fervently that their particular thing is the best. And so when we give a therapy as nephrologist, we sort of are uncomfortable with the fact that the therapy might be doing some harm because we want to help our patients. And so there's this idea is that the more dialysis, the better. Give dialysis every day, give it longer to limit ultrafiltration, blah, blah, blah. But we actually might still be doing some harm, and some of this may just be related to the fact that our circuits and running, the way we run blood through and smash it into think of this roller pump that's smashing the blood cells and moving them forward. Doing this, spending 1/3 of your life hooked up to this type of system may not really be that good for your health. And few people have actually looked at this. If you look at the CRT literature and you compare intermittent dialysis with continuous clearance, and you would think that, well, the best sort of removal to mimic the artificial kidney is to give dialysis continuously instead of intermittently, and that's CRT for you. And you can do this with CRT with hemodiafiltration. And when they looked at outcome studies of CRT versus intermittent hemodialysis, people have not been able to show a major benefit. And that suggests one of two possibilities. One is that somehow, well, there are several. One is that we're not removing the things we need to remove. Two is what you're pointing out. Maybe we're removing some things we shouldn't be removing. Or three is perhaps continuous exposure of the blood to an extracorporeal circuit causes some offsetting harms that offset any additional benefit of removing certain molecules where we may already be way up in the toxic range. So I think there's still a lot of unknowns about dialysis and dialysis adequacy, and you just have to approach it with an open mind.
Yeah. No, I think that what you just said, that's actually really important and really important guidance and advice for everyone who enters that field. Now, I see we are, I think, coming to the end of this conversation. I mean, I always feel there's one thing we shouldn't forget, that dialysis extends lives, saves lives to the millions as we speak and looking past. So dialysis is certainly contributed to the survival of many, many, many millions of people globally. And there's always this area where improvements can be made, of course, and that's why I, for example, entered the field with this elusive vision. Maybe there is a sort of renal replacement therapy that can technically renal replacement therapy that can approach the functionality of the human kidney. John, maybe as we are wrapping up, maybe in very, very brief, in 30 seconds or so, what would be a key message you would want to bring across to the audience?
I sort of think ahead of the Star Trek episode where they go back to they go back in the future, and then Bones goes to visit the hospital from the 1970s, and he says, oh, these people are savages, how they're doing it, how they're treating things. I would hope that dialysis is no longer practiced much in the 100 years from now or 50 years from now. I think we are doing a tremendous amount. I think there are patients who have lived for 30, 40 years or more on dialysis and have done very, very well. And it's unquestionable that it's a great therapy. And, my hats off to all the people who have continued to improve the therapy and the treatment. I think that there will be further improvements as we go.
I'm truly honored for a conversation with someone who has actually contributed tremendously to the improvement of that therapy. So on that note, and also what you just said earlier, always keep an open mind. Be ready for surprises. Think hard about the problems. I think that's something that eventually will move the field along and help us to improve patient outcomes. So, John, Dr. Daugirdas, thank you so much for this really fascinating conversation. I very much appreciate that, and have a good remainder of the day.
Wonderful. Thank you, Peter.